Hi folks, sorry for that abrupt interruption of the previous session. The weather in Bangalore suddenly changed for good. It's like it started drizzling and then it started pouring. Now there is hailstorms going on. Because of that, probably I lost the internet connectivity, and as soon as I lost the internet connectivity, the link for the YouTube live stream collapsed. So that's why we had that interruption. So I don't want to leave you behind with those questions and unanswered options. So the pending questions, I'm recording it from the studio and it will be relayed soon for you. Okay, so this is the question that we were discussing when the link collapsed. Patient with right heart catheterization data given below. What is the cause for pulmonary hypertension? Mean pulmonary arterial pressure is 30 millimeters of mercury. Pulmonary arterial wedge pressure is 18 and pulmonary vascular resistance is 4 Wood units. And the question was asking you what is the cause for this patient's pulmonary hypertension. So point number 1, do we agree that this patient has pulmonary hypertension? Well, if you're the one who has also attended the previous live session where we discussed the updates in the current edition of Harrison, you would have noted that the main update is for the pulmonary hypertension. Previously, the cutoff of mean pulmonary arterial pressure used to be more than or equal to 25 millimeters of mercury, right? So the diagnosis is based on mean pulmonary arterial pressure, and for that obviously we need the right heart catheterization data, because from the echo you can assess the systolic pressure well but not the diastolic pressure that well. So obviously you need the right heart catheterization. For definitive diagnosis you need the right heart catheterization. So I was asking you a question, what is the screening test of choice? So the screening test of choice is the bubble contrast echocardiography. So you introduce bubbles into patient's circulation by injecting air and then you do the echocardiography. That is called as bubble contrast echocardiography, and that is considered as the screening test of choice for pulmonary hypertension. Okay, this is a potential MCQ point, so please remember about that. Screening test of choice is bubble contrast echocardiography. Okay, and as I've already discussed, the definition of pulmonary hypertension is based on mean pulmonary arterial pressure, but recently there is a revision. So previously I told you we are following this number 75 millimeters of mercury or more than that, MPAP more than this number used to be called as pulmonary hypertension. Now that number is lowered. This is lowered to more than or equal to 20 millimeters of mercury. Okay, so there is a logical reasoning behind that. So what we know is that when you diagnose patients as having pulmonary hypertension with a MPAP of more than 25 millimeters of mercury, by that time a reasonable number of patients would have developed the right ventricular changes or right ventricular hypertrophy or right ventricular remodeling. Just like how we have left ventricular remodeling in patients with systemic hypertension, we can have the right ventricular remodeling. So that's not the right time to act, right? So the right time to act is before patients have developed right ventricular remodeling. So for that the cutoff is lowered. Okay, so currently accepted cutoff is 20 millimeters of mercury. So going back to the question, I think all of us agree that this patient has definitively pulmonary hypertension, right? So this patient has pulmonary hypertension. Now how do we further diagnose the case? From the right heart catheterization data. So in the previous question we have discussed these WHO classes. Class 1 is pulmonary arterial hypertension, most likely idiopathic. Class 2 is due to lung diseases. Class 2 is due to left heart disease. Class 3 is due to lung disease, and class 4 is chronic thromboembolic pulmonary hypertension. Okay, so one approach that we can follow for classification of the causes for pulmonary hypertension is pulmonary hypertension can be said to be pre-capillary or post-capillary. You can call it as pre-capillary or post-capillary. Okay, now what do you mean by pre-capillary and post-capillary, and which of these belong to pre and post? So the basic anatomy that we know is you have your heart, you have the right side of the heart and the left side of the heart, right atrium, right ventricle, right? So from right ventricle the blood goes to lungs, right? So from the lungs the blood is coming back to your left atrium. This is your left atrium, the blood is coming back to left atrium, right? From there it is going to your left ventricle and then it is ejected into aorta. Okay, now it is called as pre-capillary if the pathology is basically in the pulmonary artery, if the pathology is in the pulmonary artery or it is at the level of lungs. See, what is happening at the level of lungs? Pulmonary artery is bringing the blood which is not oxygenated. There is capillary meshwork, that is the capillary zone around your alveolar spaces. Oxygenation is occurring and from there the blood is moving to the left heart through the pulmonary veins, right? So up to this portion of capillaries and pulmonary artery is called as pre-capillary. After that, that is pulmonary veins, And if there is a lesion of the left side of the heart, left atrium or left ventricle, if that is causing pulmonary hypertension, that is called as post-capillary, right? So your pulmonary vein belongs to post-capillary. Pulmonary vein belongs to post-capillary. Left-sided heart lesions will be considered as post-capillary. On the other hand, pulmonary artery pathology or the lung diseases, right, will be considered as pre-capillary, right? The lung and pulmonary artery will be considered as pre-capillary. Okay, so what are the causes for pre-capillary? Obviously, number one is your idiopathic pulmonary arterial hypertension. Pulmonary arterial hypertension, that is pre-capillary. The pathology is in the pulmonary artery. There is increased pulmonary artery vascular resistance, just like how the systemic vascular resistance increases in systemic hypertension. Okay, number two, if you are having lung diseases, right? If it is secondary to lung disease, that will also be considered as pre-capillary. Okay, now where do you place the chronic thromboembolic pulmonary hypertension? Obviously, again pre-capillary, right? It is the pulmonary artery where embolic showers are loading the clots. So that is also your pre-capillary. Third one is your chronic thromboembolic pulmonary hypertension. Okay, if you have the occlusion of the pulmonary vein, so there is a condition called as pulmonary veno-occlusive disease. It's a very rare idiopathic condition, pulmonary veno-occlusive disease. It's very rare and it is idiopathic. Right now we don't know the cause. For some unknown reason, pulmonary veins become occluded, right? That is called as pulmonary veno-occlusive disease. So obviously that will be post-capillary. Okay, now where do you place the pathology of left heart failure? If there is left ventricular failure or left atrial pressure rising because of valvular lesions, where do you place that? Okay, so now from the catheterization data, what tells you that there is a post-capillary involvement? And from the catheterization data, what tells you that the pulmonary artery is the site of pathology, right? The marker of pulmonary artery involvement, pulmonary artery direct involvement, that marker is your pulmonary vascular resistance. Resistance high, then the pulmonary artery is part of the pathology. If the resistance is normal, pulmonary artery is not part of the pathology. Something else is the disorder where pulmonary artery's pressure is increasing. For example, if I talk about pulmonary veno-occlusive disease. Now in pulmonary veno-occlusive disease, what is happening? Pulmonary veins are occluded, right? So because of the occlusion of the pulmonary veins, obviously there is back pressure, right? At the capillary meshwork, there is difficulty in forward flow of the blood. So there is increased pressure in the pulmonary artery, and the patient is being diagnosed as pulmonary hypertension because the pulmonary artery mean pulmonary arterial pressure is elevated, right? But pulmonary vascular resistance in that case is not increased, right? So pulmonary veno-occlusive disease is a case where there is isolated post-capillary defect. Isolated post-capillary defect. Okay, now comes the patients of left heart failure, right? Left heart failure. In left heart failure, the pathology is pre-capillary as well as post-capillary. Okay, now what do I mean by that? In left heart failure, okay, you can take an example. If there is a left ventricular failure, obviously the left atrium is having difficulty to expel the blood into the left ventricle because it is non-compliant, it is stiff, or there is a dilatation and the ejection fraction is reduced, so the previous cycle's blood is not ejected or cleared from the left ventricle. So left atrium has more work to do to push the blood into the left ventricle. So because of that, left atrial pressure would increase. If the left atrial pressure is increasing, pulmonary venous congestion occurs, pulmonary venous pressure increases at the level of lungs, right? The pressure in the capillaries meshwork increases, so is the pressure in the pulmonary artery increasing. But what happens to pulmonary vascular resistance in case of left heart failure? Okay, so when there is heart failure occurring, there are various neuromodulatory changes happening. Those neuromodulatory changes can increase. Just like how they can increase the peripheral vascular resistance, they can increase the pulmonary vascular resistance also. So left heart failure is a condition where you have post-capillary defect plus the pulmonary artery vascular resistance is increased. So it is a combination of pre-capillary plus post-capillary. It is pre plus post-capillary defect. Right? So you got the point? That's the basic understanding we have. Okay, now how we evaluate a case? I am just bringing in one of the algorithm from the Harrison. So we will start, when you get the right heart catheterization, we will start by confirming the pulmonary hypertension. That is, you're looking at the mean PAP. If it is more than 20 millimeters of mercury, yes, there is pulmonary hypertension present. If it is less than that, pulmonary hypertension is obviously ruled out. If at all patient is symptomatic and you are thinking pulmonary hypertension, look for other possible causes for the similar symptoms. Once you confirm that there is pulmonary hypertension, the next thing we will be looking at is pulmonary artery wedge pressure. If pulmonary artery wedge pressure is increased, right, that means there is a post-capillary defect. That means there is a post-capillary defect. So if that is increased, there is a post-capillary defect. Right. So the next thing you will be looking at is the pulmonary vascular resistance. See, if you remember from the previous algorithm, I said post-capillary defects. There are two possible causes. One is pulmonary veno-occlusive disease, where there is isolated pulmonary, isolated post-capillary pathology, and the left heart pathology, where there is pre as well as post-capillary. So you can have pulmonary vascular resistance increase in the left heart failure along with the pulmonary artery wedge pressure increased. Right. Okay, so that is what this algorithm talks about. Pulmonary vascular resistance more than or equal to 3 Wood units. That's the unit used for expressing the pulmonary vascular resistance. More than or equal to 3 Wood units. If this is there, that means there is pulmonary vascular resistance increased, right? So that means there is a pre-capillary component also included. So it's a pre and post-capillary component included. And the classical example for that I could think of is left heart failure. Right. Okay, then you have an isolated post-capillary defect, which can be in case of the pulmonary veno-occlusive diseases. You can have an isolated post-capillary defect, right? So left heart failure is both isolated post-capillary defect or a combination of pre and post. Left heart failure is predominantly a combination of pre and post both, and your pulmonary veno-occlusive disease, that is your isolated post-capillary defect, right? Okay, now if the pulmonary artery wedge pressure is not more than 15 millimeters of mercury, that means there is no post-capillary component, it is pre-capillary. So what are the causes we thought of for the pre-capillary? We thought about the lung diseases, we thought about the idiopathic pulmonary hypertension and chronic thromboembolic pulmonary hypertension and certain miscellaneous rare conditions. So all of them come here. But obviously if that is the case, pulmonary vascular resistance should be increased. If the pulmonary artery wedge pressure is less than 15 millimeters of mercury, post-capillary is ruled. So there has to be a pathology of the pulmonary artery or the lungs. So the pulmonary vascular resistance in that case should be increased, right? So all this pre-capillary pictures come into picture. So WHO group 1 is what? That is your idiopathic pulmonary arterial hypertension. Group 3 is which one? Due to lung disease. Group 4 is chronic thromboembolic, and group 5 is some rare diseases. Right? All of them will come into picture, pre-capillary. Right? So this is the algorithm. Okay, now having understood this algorithm, let us go back to the question and address that. Okay, so we have all the information needed for us. The diagnosis of pulmonary hypertension is agreed upon. Mean pulmonary arterial pressure is 30 millimeters of mercury. Pulmonary artery wedge pressure is 18 millimeters of mercury. Now what does that mean? When pulmonary artery wedge pressure is 18 millimeters of mercury, that is definitely there is a post-capillary component involved. Right? There is a post-capillary component involved. So we had thought about two causes for post-capillary component. One is pulmonary veno-occlusive disease. The other one is left heart pathology. Okay. And what point I told you? The left heart pathology, there is pre and post-capillary component. So pulmonary vascular resistance can be increased in left heart failure. Okay. So the pulmonary vascular resistance here is 4 Wood unit. The sign of pre-capillary component is pre-capillary involvement is pulmonary vascular resistance more than or equal to 3 Wood units. So here it is 4, so that is elevated. So what are we dealing with? Pulmonary hypertension with pre as well as post-capillary component. Chronic thromboembolic pulmonary hypertension is only pre. So in that case, pulmonary artery wedge pressure will be less than 15 and pulmonary vascular resistance will be more than or equal to 3 Wood units. Okay, pulmonary hypertension due to lung disease, again a pre-pathology. So here also similar picture, pulmonary artery wedge pressure should be less than 15 and pulmonary vascular resistance should be more than or equal to 3 Wood units. Okay, primary pulmonary hypertension, again the same picture, right? So your pulmonary arterial wedge pressure, because there is no post-capillary component, should be less than 15 millimeters of mercury. Pulmonary vascular resistance should be more than or equal to 3 Wood units. So that brings us to the answer for the question, that is option A, left heart failure. In that case, in case of left heart failure and the pulmonary veno-occlusive disease, we will be expecting the pulmonary arterial wedge pressure more than or equal to 15 millimeters of mercury. And if it is left heart failure, there can be a pulmonary vascular resistance increased. So your pulmonary vascular resistance can be more than or equal to 3 Wood unit. So that makes option A as the right answer. Left heart failure is the reason for this patient's pulmonary arterial hypertension, right? Okay, so that concludes this question. Right answer is option A, left heart failure. Okay, now let me take you to the final question for the day. A patient was suspected of having pulmonary arterial hypertension, which was confirmed on right heart catheterization. Upon vasodilatory testing, his mean pulmonary arterial pressure decreased to 32 millimeters of mercury from 38 millimeters of mercury. He should be treated with which of the following drugs? Tadalafil, acetazolamide, tadalafil plus ambrisentan, or amlodipine, right? Okay, so what is the information available here? It is already considered as a pulmonary arterial hypertension case, right? It is suspected, and we have the right heart catheterization data, and they have told that mean pulmonary arterial pressure decreased to 32 millimeters from 38. So to start with, it was 38 millimeters of mercury. That is definitely high. More than 20 is considered as diagnostic cutoff, just like we discussed in the previous question. So the diagnosis of pulmonary hypertension is confirmed, right? Because MPAP is more than, or it's definitely more than 20 millimeters of mercury. Diagnosis is confirmed. Now, once you diagnose the case as pulmonary hypertension, now what are the possible causes? That approach we have already discussed. So in this case, they are making it clear. When they talk about vasodilatory testing, they are basically talking about idiopathic or pulmonary arterial hypertension, not because of any cause. If it is because of a cause, treating the cause is the only thing that we can offer. If it is left heart failure, which is responsible for pulmonary hypertension, or a left heart pathology, valvular lesions, treat the underlying cause. If it is a lung disease, treat the underlying cause. Like COPD causing pulmonary hypertension, treat the COPD. That's the approach, right? If there is a cause, treat the cause. But if it is idiopathic pulmonary hypertension, right, that is where vasodilatory testing comes into picture. So the fact that he has mentioned the vasodilatory testing data, he is talking about idiopathic pulmonary arterial hypertension. Okay, so this question is about approach to idiopathic pulmonary arterial hypertension. So how do we approach? What is the relevance of knowing this vasodilatory testing, right? That's the question. Options here are tadalafil, acetazolamide, a combination of tadalafil plus ambrisentan, or amlodipine, right? Okay, so vasodilatory testing is part of your right heart catheterization process. So when you do right heart catheterization, if it is a idiopathic pulmonary hypertension, or if the right heart catheterization data tells you that this is pulmonary arterial hypertension, and you already know from the history and lung imaging that it is not a lung disease, you already know from the echo and other right heart catheterization parameters, looking at the pulmonary arterial wedge pressure, you know that there is no post-capillary defect, it is primarily a pulmonary arterial disease, then you will do the pulmonary vasodilatory testing, right? So in the vasodilatory testing, if there is a satisfactory vasodilatory response, then the drug of choice for treating such patients is usually dihydropyridine calcium channel blockers like amlodipine. If the vasodilatory response is not satisfactory, then you treat it with alternative agents. That's the basic essence that we need to know. And how many patients generally show a positive vasodilatory response? Around 5% or less than that. So 5% of the patients can have a positive vasodilatory test, and in those cases, dihydropyridine CCBs are considered as the drug of choice. And remaining 95% who have a negative vasodilatory testing, in them the drug of choice is the alternatives. And there again, additional parameters come into picture. We need to know the risk of the patient to decide whether you want to manage with a single drug or a combination of drugs, or whether you want to manage with a combination of IV plus oral. That comes into picture once the vasodilatory testing is negative. Okay, now before I go to the vasodilatory testing, just a quick look at the goals of treatment of idiopathic pulmonary hypertension. Secondary pulmonary hypertension, I've already told you, treat the underlying cause. Some degree of improvement in the pulmonary vascular parameters can be expected. And idiopathic pulmonary hypertension goals are basically these: minimal symptoms, and the WHO functional class 1 or 2. Then we can also look at 6-minute walk distance I think this 6-minute walk became very famous during the COVID. That is what also used in case of assessing the patient's response to treatment in patients with pulmonary hypertension, idiopathic ones. 6-minute walk distance. So patient should be made to walk comfortably for like up to, in 6 minutes he should be able to complete 440 meters. That's our goal, right? So close to half a kilometer he should be able to walk within 6 minutes. That's the goal. Okay, that's really a tough goal because of late I've started walking and I cannot really complete 1 kilometer in 12 minutes. So that obviously means if you extrapolate it to 6 minutes, probably even I would struggle. But that's the goal that we want to achieve in patients with pulmonary arterial hypertension. And if you look at the cardiac index, then 2.5 liter per minute. That's the cardiac index goal, right? All of these are MCQ points, particularly the 6-minute walk distance. This is an MCQ point, and your cardiac index, that's an MCQ point, right? Okay. Now comes the vasodilatory testing. So once you confirm that it is a idiopathic pulmonary arterial hypertension, you do the vasodilatory testing. For that, you can use any short-acting inhaled vasodilatory agent. That could be nitric oxide or epoprostenol, which are available as inhaled form. Now, what are we looking at? We are looking at the reduction in mean pulmonary arterial pressure, a reduction of more than or equal to 10 millimeters of mercury from its baseline, right? From its baseline to an absolute level of less than 40 millimeters of mercury. That means I'm giving you a hypothetical number. So let me start with patient having 45. Pre-bronchodilator, his mean pulmonary arterial pressure is 45 and I reduce it to less than, okay, I reduce it to, let me say, a number of 35. Right, so it is more than or equal to 10 millimeters mercury reduction in the mean pulmonary arterial pressure after the inhaled vasodilators, and the final value is less than 40. Right? Both these criteria should be satisfied to an absolute level of less than 40 without decrease in the cardiac output. So during the catheterization, you are also calculating the cardiac output without decreasing the cardiac output. If you achieve this parameter by reducing the cardiac output, that's not what we are aiming for, right? So if that is what you are aiming for, then you will not be able to achieve this 6-minute walk distance. You will not be able to achieve the cardiac index without reducing the cardiac output. That will be said to be positive pulmonary vasodilatory response. Let me give you another hypothetical number. Patient's starting point of pulmonary MPAP was, let me say, 52 millimeters of mercury, right? After vasodilatory testing, let me say it became 41 millimeters of mercury. It is more than 10 millimeter of mercury decrease in MPAP, yes, but is it the final value? The absolute value is less than 40? No. Right? So such patients will also be termed as negative vasodilatory responders. So in those cases, again, you will not be using the dihydropyridine calcium channel blockers. So in that case, you will be looking at alternatives if there is a negative vasodilatory testing. Now, when you have to make a choice of alternatives, what are the guiding principles? So this is the algorithm that you find in your Harrison. Okay, so vasodilatory test positive, calcium channel blockers. If it is negative, you will do the risk assessment. High risk individuals, we treat them with a combination therapy of a IV agent plus an oral agent. Okay. Low risk individuals, again a combination therapy is preferred over a monotherapy. Monotherapy is only for patients with positive vasodilatory testing, right? So what is the combination therapy you will be using? You will be using a combination of oral agents, 2 or more than 2 oral agents, right? If you start with 2 agents and if it fails to achieve the target, we have already defined the goals, you're not able to achieve the goals with these 2 agents, whatever you started, then you will go to triple therapy where you will be adding a third drug, right? And if that is also failing, then maybe last thing, as a last resort, you can think of lung transplantation. That's the last resort. Okay. Now, how do you define high risk? There are various scoring systems used for defining the high risk. One is called as French registry equation. There is an NIH equation. Then there is a Reveal registry risk score. Okay, but the simplest thing that you need to remember, like if you're following the NEET SS examination, probably those scores, rarely encountered scores, are not commonly asked. So if there is an MCQ where examiner wants you to consider that case as a high risk case, where he wants you to pick up a combination of IV therapy as the treatment of choice, then probably he will be talking about either patient having hemodynamic compromise or hypotension or right heart failure, right heart failure as a consequence of the pulmonary hypertension, or the patient who is having severe symptoms in the form of syncope or LOC, right? Those will be considered as high risk patients. LOC, syncopes, or right heart failure. Already right heart failure is certain. There is raised JVP, there is pedal edema, there is tender hepatomegaly. Okay, those patients will be considered as high risk. In them, we use a combination of an oral agent plus an IV agent, right? Okay, IV agents available are basically prostanoids like epoprostenol or treprostinil is available as IV agent, and some of the phosphodiesterase inhibitors are now available as IV agent. So, but preferable IV agent is a prostanoid, an IV prostanoid, which is usually given as a continuous infusion plus a oral agent. That would be the approach. The oral agent could be your ambrisentan or your bosentan, your endothelin receptor blockers or phosphodiesterase inhibitors plus the IV prostanoid. That's the approach followed in high risk patients. Okay, I'm taking you back to the question now. This is the question we had. Suspected of having pulmonary arterial hypertension. On right heart catheterization, the pulmonary hypertension is confirmed on vasodilatory testing. From the pre-testing of 38 to it decreased to 32. Right? Is that more than or equal to 10 millimeter drop? Obviously no. So vasodilatory testing is negative. Right? So the vasodilatory testing is negative. And what did we learn from the algorithm? Right? We right now prefer combination therapy. If the vasodilatory testing is negative, no longer solo therapy is preferred. Right? So option A is ruled out. Tadalafil is not a drug of choice. Okay, acetazolamide, obviously not a preferred drug for treatment of pulmonary hypertension per se. Like where do we use it? Maybe patients patients at risk of developing the high altitude pulmonary edema, or those who have already developed high altitude pulmonary edema or high altitude cerebral edema. Maybe you can use it there, right? Not in a case of the pulmonary arterial hypertension per se. Ruled out. Anyway, it's a solo drug, ruled out. Amlodipine is ruled out because the vasodilatory testing is negative. So we are left with only option C, and that becomes a sensible choice. Now, is there any information about the high risk features present in the question? Hemodynamic instability or right heart failure or LOC or syncope episodes? No, right? And none of the scoring systems high risk features are also being mentioned. So it is a low risk case. So low risk case, combination therapy of oral drugs, right? So option C is the correct answer. Tadalafil plus ambrisentan. That's the right answer, right? Okay, so that was the question. Let me see if we have any more questions to address. Yeah, this is the last question for the day. Not a feature of acute eosinophilic pneumonia, right? What are the options? ARDS-like presentation, most common in males between the age group of 20 to 40 years. Ball fluid of more than or equal to 25%. Ball fluid eosinophil, so more than or equal to 25% of the total cells, and peripheral blood eosinophil count more than 500 at the onset of symptoms. Which one of this is a false statement? Okay, so basically what we need to know is, in case of the eosinophilic pneumonia, there are two types: acute eosinophilic pneumonia and chronic eosinophilic pneumonia, right? So some basic things we need to know about them. When you talk about acute eosinophilic pneumonia, okay, first point you need to know is how do you differentiate it from, forget about chronic eosinophilic pneumonia. We are familiar with something called as hypereosinophilic syndromes, right? How do you distinguish it from hypereosinophilic syndrome? Okay, acute eosinophilic pneumonia and chronic eosinophilic pneumonias are primarily lung disorders where there is eosinophilic inflammation. Now, the hypereosinophilic syndrome are characterized by some features, right? Hypereosinophilic syndrome. One is there can be eosinophilic involvement of the lungs, but apart from that, right? So in hypereosinophilic syndrome, there is increased eosinophil count, which for the diagnostic purpose should be more than or equal to 1500 per cubic millimeter, right? Or for microliter, more than 1500. And patient should be symptomatic, okay? The duration of the symptom should be more than or equal to 6 months. And the eosinophil count should be elevated more than 1500 for 6 months, and duration of patient symptoms should be more than 6 months. And the third point you need to know about the hypereosinophilic syndromes is, in hypereosinophilic syndromes, there is organ damage, right? So it's a systemic disease where there is organ damage present. So there is end organ damage in the form of eosinophilic enteritis, eosinophilic pneumonitis, eosinophilic other organ involvement, that should be there. And most cases of hypereosinophilic syndrome are secondary to malignancies, right? They are secondary to malignancies. So that way, the acute eosinophilic pneumonia and your chronic eosinophilic pneumonias are primarily disorders of the lungs, right? Okay, so that is one point. Now, how acute eosinophilic pneumonia is different from chronic eosinophilic pneumonia? Okay, acute eosinophilic pneumonia, the usual presentation is in the form of ARDS, right? So an unexplained ARDS, that's the way these patients present, right? These patients will be brought with the shortness of breath, hypoxia, and respiratory distress. When you look at the X-ray, classical ARDS picture, bilateral bat wing distribution or diffuse distribution of the opacities, and you will consider this case as ARDS because now we follow the Berlin criteria. You don't need the right heart catheterization. You do an echo probably turns out to be normal, right? That's your starting point. Now, what makes you think that this patient has got acute eosinophilic pneumonia? For some reason, you do a bronchoalveolar lavage because the direct evidence of ARDS is not there. I shouldn't say direct evidence. The direct evidence of etiology of ARDS is not there. Like you don't know what caused the ARDS. Patient is not in sepsis. All cultures are turning out to be negative. Your evaluation for the cause for ARDS is not yielding results. So you end up doing bronchoalveolar lavage, right? So when you do BAL, when you notice that there are more than or equal to 25% of the cells are eosinophils, that is the point where you start thinking of acute eosinophilic pneumonia, right? More than or equal to 25%, you start thinking of acute eosinophilic pneumonia. So this is your first potential clue. BAL fluid eosinophil counts more than 25%. That's the first potential clue, right? Okay. Now, the second point you need to know about acute eosinophilic pneumonia is acute eosinophilic pneumonia is typically seen in patients who are smokers, who have generally initiated smoking recently, right? It's like, okay, 1 month, 2 months back, I started smoking and now I presented with an ARDS-like picture. That's the usual story, right? Okay, so the third point you need to know is, do they have the peripheral eosinophilia at the time of presentation? We know there is eosinophilic inflammation of the lung. The trigger event could be initiation of smoking. That's what we know about it. Will there be peripheral eosinophilia? At least not at the time of presentation, or at least not in the first week of symptom onset. And first week of symptom onset is the severe phase. Most patients land up in hospital because it is the usual ARDS-like picture, right? So for more than 1 week, there will be no peripheral eosinophilia. After that, yes, peripheral eosinophilia can appear. So basically, you can believe that eosinophilia started with the lungs. So there is eosinophil recruitment at the lungs to cause inflammation, and later on there is pilferage of eosinophils to the peripheral circulation. That's how you can remember it, right? So initially, you will not have no peripheral eosinophilia. There is no peripheral eosinophilia for at least 1 week of the onset of symptoms, right? Okay, now how do you treat these patients? Fortunately, patients with eosinophilic pneumonia, and for that matter, wherever there is eosinophilic inflammation, there is an excellent response to steroids. So they respond very well to steroids. So the prognosis of treated cases is very good. So you can assume that recovery is the rule, right? If you diagnose that this is a definitive case of acute eosinophilic pneumonia and you initiate steroids, recovery is the rule, mortality is negligible. Undiagnosed, they will behave like any other case of ARDS and it will be associated with very high mortality, right? Okay, so that's what we need to know about acute eosinophilic pneumonia. What we need to know about the chronic eosinophilic pneumonia. Chronic eosinophilic pneumonia. Okay, so the basic thing you need to know about the chronic eosinophilic pneumonia is obviously it is chronic. It is typically seen in non-smokers. And most of these, okay, this point I forgot to tell you. Usually acute eosinophilic pneumonia patients are non-asthmatics. So your chronic eosinophilic pneumonia is relatively common in asthmatics or those who have history of atopy, right? So these patients present with cough and shortness of breath. Sometimes it is like first initially case is diagnosed as a difficult to treat asthma or a refractory asthma, but when you do imaging, that is where you start thinking that this could be chronic eosinophilic pneumonia, right? So that means we should know what is the imaging finding we are looking at. Okay, so in patients with chronic eosinophilic pneumonia, acute eosinophilic pneumonia, ARDS like chest X-ray. In case of chronic eosinophilic pneumonia, you will see eosinophilic inflammatory consolidations which are peripherally distributed, right? So if this is your X-ray, this are your lung fields, then you will have consolidations which are peripherally distributed. You may have the classical findings of consolidation like air bronchogram and all. These consolidations are peripherally distributed. So you have white opacities which are peripherally distributed, which could be unilateral or bilateral, which could be mild or which could be extensive. When it is extensive, right, so you have peripheral consolidations. When it is extensive, these peripheral consolidations are basically pleura based, right? The base of this consolidation is pleura and the wedge is facing towards the mediastinum. Consolidation, peripheral consolidation. If there are multiple of these and bilateral, right, if there is bilateral and extensive, that leads to some finding called as, I think this is the sign you are familiar with, it is called as photographic negative pulmonary edema. Photographic negative pulmonary edema. It is not a case of pulmonary edema, it is the consolidations which are responsible for opacities, but the distribution of these opacities, because they are peripheral, right, on an X-ray, the classical area where you see the bat's wing distribution of opacities in pulmonary edema, those areas are spared, and the areas where this bat's wing distribution is not there, those are the areas where you are seeing the opacities, right? So it looks like the negative image of a patient with pulmonary edema. That's why it's called as photographic negative pulmonary edema. It is a highly specific finding, but less commonly seen. Highly specific, but seen under 20% to 25% of the patients with chronic eosinophilic pneumonia. If it is present with the right history, it is highly specific. Okay. Now that we know these patients are asthmatic, they may be having the pre-existing eosinophilia as such, right? So at the time of diagnosis, there will be peripheral eosinophilia. There will be peripheral eosinophilia at the time of diagnosis itself, right? Okay, so this is the basic thing we need to know about chronic eosinophilic pneumonia. In terms of treatment, again, eosinophilic inflammation, so excellent response to steroids, mortality is negligible. Okay, so let us go back to the question now. Question is not a feature of acute eosinophilic pneumonia. ARDS like presentation, yes, that's what we discussed, right? These patients usually present with the picture of ARDS. And until and unless you suspect acute eosinophilic pneumonia, there's no way you will diagnose it, right? So you suspect, do a BAL, and then you notice that there are eosinophils which are more than 25% of the total BAL fluid cells. That is where you think that, okay, I am dealing with a case of acute eosinophilic pneumonia. So statement number A is true. It is usually presenting in the form of ARDS like picture. BAL fluid eosinophil count is more than 25%. That is true. That's a true statement. Males between 20 to 40 years are usually affected. That's also a true statement. Okay, this you can easily remember, right? That's the age group 20 to 40 where patients start puffing their first smoke. Okay, you might say that I started in my teenage. I agree, but that's the usual age, right? So that's how it's like you start smoking 1 or 2 months later, there is a eosinophilic inflammation of the lungs, and you develop ARDS like clinical picture, you land up in the hospital. Your intensivist initially fanatically looks for a cause for ARDS. When he doesn't find a cause, he decides to do a bronchoalveolar lavage, and then eosinophil counts are more than 25%. That is where he diagnoses the case as acute eosinophilic pneumonia. Then he starts steroids. Till that time, he will be playing with his ventilatory settings. But once the BAL fluid report is there, you may be on ventilator, but then he introduces a genuine dose of steroids, and after that, within 1 or 2 days, there will be dramatic improvement, right? Even extubation. I remember, like my last patient, we could extubate within 48 hours of starting steroids in acute eosinophilic pneumonia. I have seen only 2 patients, and in 1 patient we could extubate, which was initially suspected as having ARDS. Okay, that brings me to the last point. Peripheral blood eosinophil count of more than 500 at onset of symptoms. Obviously, that's the false statement, right? So more than 500 is considered as elevated, less than 500 can be considered as normal. 1500 is the number for hypereosinophilic syndrome with the end organ damage. Here, at the time of presentation, we are not expecting the peripheral eosinophil count to be elevated. That will be normal. 1 week down the line, it might become elevated. It can even reach 1500. But in the first week, it is generally normal. So that's the false statement. Okay, so that concludes our discussion for the day. I'll be coming back with similar MCQs in the next live session. We'll try to concentrate on endo and neurology in the subsequent sessions. For now, I'm signing off, and humble apologies for that technical glitch because it started raining badly. There was like hailstorm and lightning, and I lost connectivity for a moment, but the system actually breaks off once there is a connectivity. The link generally dies. So I had to record this and bring it in front of you. Thank you guys for connecting, and see you soon.